Hello and welcome to today's episode of the Pediatric Consult. I'm Dr. Paul Bunch, a community pediatrician and your host for today. I'm very excited to welcome today's guests, Dr. Brenda Thompson and Sarah Bantel, both from the Division of Speech and Language Pathology here at Cincinnati Children's. Today's discussion is something I deal with on a daily basis, so I'm very excited to learn from the experts. Today's topic is picky eating. So, Brenda, Sarah, thank you so much for joining us. If you don't mind, could you introduce yourselves, tell us a little bit about your background, your clinical experiences, any interests in the hospital, outside the hospital?
Sure. This is Brenda Thompson. I am a pediatric speech pathologist. I've been practicing for 29 years. 24 of them have been here at Children's Hospital, and most of my career I've worked with preemies in the neonatal intensive care unit and neonatal follow-up. Spend a lot of time working with families who have children with medically complex conditions that impact their feeding and their development, actually. And in terms of my interests, I'm really interested in quality improvement and evidence-based practice and really trying to find strategies that really support just global outcomes for our infants because they start off with some challenges.
And my name's Sarah Bantel, and I've been a practicing speech pathologist for 20 years, and I've been at Cincinnati Children's Hospital for all 20 years. Some of my interests at the hospital include multidisciplinary, interdisciplinary care for our complex kids who have started off with a variety of challenges, and feeding happens to be one of those. Some of my other interest is I am an avid fan of all Cincinnati sports, and I love to go to all those different games.
Well, thank you guys for joining us. So as I said, today's topic I'm excited about because as a primary care pediatrician, this is a daily conversation. Parents across the board are always worried that their kids are picky eaters, they're not getting the right nutrition. So can we start by just defining picky eating? In your guys' practice, who would you say actually is picky versus normal childhood, food preferences?
Yeah, that is the million-dollar question, actually. And, I think it's probably one of the top concerns we get from families. If you think about feeding, it's something that everybody has to do. And it is a life skill, and it starts literally from the moment you're born. And so anytime there's a disruption, because you have to eat multiple times a day, it really can become a battle quickly. Families, I think they expect that their child is going to eat, and when there is a problem, it can be unnerving for them. It creates a lot of stress, and if there's any associated medical conditions that then maybe result from it or it occurs from, I think it just amplifies the concern that families can have. So, I think that picky eating is a very subjective term, actually, and I think it's both a common language term that you hear very on social media, in reading, you hear certainly our patients and families and colleagues talking about, but it's actually a clinical defining characteristic of feeding development also. So what we would say picky eating is anytime you've got a child who restricts what they will accept because there's something about certain foods or certain textures that just doesn't jive with them, or they're limited in terms of their total intake. They need a lot of encouragement to eat. I think, though, if you talk with families and if you look at some research that we can get into today, it really is defined very differently depending on which family that you talk to.
I think so many families bring their own cultural experiences and their own history into what a feeding experience and what those expectations in their households may be. And that is one additional layer when you're thinking about globally, what do we need from a nutritional intake perspective and a growth intake perspective. But so much of the feeding experience is parent-child dynamic and family experience regarding what is offered generally in their household, what's acceptable when they think about volume, and what that looks like throughout their day.
And I think the words like normal and typical are probably kind of loaded in this conversation, but how would you guys describe normal or typical, development of kids in their food intake? Obviously in the first 6 to 9 months, it's primarily milk, whether it's formula or breast milk, but then around that 6 to 9 months is when they start introducing foods, what would you guys expect as the experts?
Well, I feel like sometimes it's helpful to start at the beginning. So infant feeding is reflexively driven, and that's beautiful the way the humans were designed, actually, because we are not born to walk and do things for several months. So those reflexes we really depend on. And so even medically complex kids can actually look good feeding in the very beginning of life. However, you get to about 2 to 3 months of age, and those reflexes start getting integrated. And if you don't have a skill set to support feeding, you might start seeing some challenges. And so there's a lot of transitions that happen in the first year of life more than anything. You're moving from an all-liquid diet to puree that gets thicker, to other lumps that then kind of come into your foods that require biting and chewing, spoon use, cup drinking, etc. And so in the first 12 months, you're really going through so many different transitions. It's common to see little hiccups at different points. And really, the difference between what is maybe a feeding disorder versus what is maybe just a temporary condition is related to how substantial the effect is on a child. If it persists more than a couple of weeks, I think that is usually more of an indicator that there's a concern. And certainly if it inhibits transition to age-appropriate foods or solids or utensil use even, persistent use of a bottle for months after the 12th month. All of those things are sort of indicators that there's something going on until a clinical evaluation is done. You don't know exactly what's driving it. It could be a motor behavior. It could be a medical condition. It could be a sensory dysfunction. So there's any number of things that could contribute, but there is a lot of typical development where kids are, they're learning about the world and they're learning how they have some autonomy themselves to kind of control their behavior in their own world, right? And so, something that looks new to them, they might look at it with suspicion. I think from an evolutionary perspective, that is actually a reflex that we are born to maybe be suspicious of things that we're not sure if are safe for us, right? Unfortunately, for some kids, that little evolutionary piece can be pretty substantial for them, and it can really allow them to not like bitter foods that are usually vegetables for a pretty prolonged period of time. And it might take some therapeutic intervention, some sensory work to kind of work to overcome that.
I think when we also think about some of those motor skills that have to occur within that first year of development, both from a gross motor perspective, fine motor perspective, and an oral motor perspective, that can impact a child's willingness and success in moving from a liquid diet to a puree diet to a soft solid diet, which can inhibit what volume and what variety they may be willing to accept. And so all of those different areas and those transitions happen relatively quickly. And if there's a hiccup that takes a little bit longer, it can impact their success in moving to that next thing, which can then impact moving to a more, larger variety and table foods that a family may be offering on a regular basis.
And in my clinic and my experience, usually I find like the 9 to 12-month-olds, even the 12 to 15-month-olds, they like to eat everything.
Yep.
They're excited. I always tell parents, they're excited they get to eat the big people food.
That's right.
They see you eating it.
They're watching.
Yeah.
And they're watching and like, I get to do this too.
Yep.
And then around 15 to 18 months, that starts to narrow down. They don't want to eat as many things. I'm sure some of it has to do with the independence and all. Is there anything else that factors into that, narrowing down of the type of foods that they like to eat around that, 12 or 15 to 18-month-old range?
Yeah, actually, I think that it's a combination of picky eating tends to peak close to about 2 years of age. So we expect that kids, as they kind of get more control, they might learn that some things just have better taste for them. We all are a little different in terms of how we respond to taste. Some of us really prefer sweet. Some of us prefer more of a savory. I don't know many people who really love bitter, but those people are out there as well. But many of us like to have a variety, and some people are very, very regimented. They want the same texture, they want the same flavor. And so when you get to be about 18 months, I think it's typical you've probably been exposed to a very wide variety of different foods, possibly in your own home as well as maybe in a daycare environment as well. We frequently will find children in daycare environments just because of peer modeling. You really get a lot of great exposure. So you might get exposure to things that you don't have in your home, and you might start to see, oh, they don't like that. Well, maybe that's great insight for families to go, let me give that a try at home. Yeah. Because actually evidence shows you need to try something 15 to 20 times before kids will decide if they like it or not. And there's some good research that suggests that many families fail to persist offering those things after about 5 refusals because they're like, what's the point? I mean, food is expensive, right? Yep. And you don't want to waste, and you don't want feeding to be a battle. So if it's going to be refused, it's very easy when we're busy to just go, well, they aren't going to take it, so I'm not even going to bother. But what is critically important is that we're constantly offering, maybe not requiring, maybe not forcing, but just offering and modeling that we're going to eat it, and that's just all part of the typical mealtime routine.
And that can start,
it can start
around 12 months or
sure
even
can.
sooner than that of offering and modeling. Good.
Yep, it's great stuff.
And I think the idea, like Brenda had said, is that, some of the independence of a kid, that I can have a pretty large behavioral response. And for a lot of families, that's a tricky spot because they want them to eat. They want them to leave that meal feeling full, feeling satisfied. And so they start to stop offering some of those foods that have been tricky or have been a no for whatever reason. And so offering some things on a consistent basis. And I think for so many families, a few times of no, and then it's a no thank you. And so having just even a little sheet on the refrigerator that you put those things down, and just keeping track a little bit more of, oh my gosh, I didn't even think about that. We haven't offered broccoli in 3 months. Maybe we go back and give that a try, because they're changing so dramatically and so quickly also as small people. And so things that didn't work a little bit ago may be more successful now. So being able to return to that with the idea of it needs to stay there. They can experience the smell, the look, what the texture might be if they touch it, but there's not the expectation that they're going to be consuming that food right now.
I think you just made the greatest point right there. In the age of apps, we have a great opportunity actually to track the foods that we're offering. And there's some really nice apps actually where families can kind of track when was the last time I offered it. And there's a lot of great support to say maybe not at mealtime, maybe it's at snack time. Maybe it's a child who likes it with maybe a dip associated with it that just changes the flavor a little bit, and it looks like a French fry getting dipped in ketchup, for example. So you can be successful by trying it and just trying it in different ways. But I think from a clinical experience, what we see more than anything is exposure in a respectful way and really watching their cues, I should say, very closely tends to be very associated with a more positive outcome in terms of acceptance. When you get into a battle, it's like you almost have to agree to disagree, give it a break, and come back to it later. And like you said, maybe it's a couple of weeks, maybe it's a month, but just giving it a break and saying, don't even push it. Let's just try again in several weeks. Keep doing what you're doing with the foods that they'll accept, and we'll get there.
And, 18 months to 2 is when these things tend to peak. Yep. Is there an age where you see most kids growing out of this very picky phase, very controlling of their intake phase?
Yeah. Well, I think that certainly there is a percentage of the population that will remain sort of fixated on what they want. But in terms of kind of your average picky eater, I would say about the age of 3, they've had a lot of exposure by that point. But, we can talk today about behaviors that might indicate more of a pressing, persistent kind of feeding challenge that might need some assessment. And that can happen literally anywhere from newborn up to, well, at any point, pending if you have an illness or an injury, certainly that could impact you. But in terms of just typical development, usually by 24 to 36 months, you've got a really solid foundation for feeding. And unless something intervenes to impact that, you should be good sailing at that point.
So yeah, I think that's very important to kind of know what the typical ranges are. And one thing that I've seen very often in my office is the amount of food that kids eat goes down at that same time window.
Sure
So they
does.
get this appetite slump, so parents worry about that too. Or they eat really well at daycare
Yep.
because of the peer pressure, but then they don't eat dinner at home. And I say that's very normal. They're typically going to eat one good meal a day during this phase.
Right.
What are some things that we can use to reassure parents during this time that everything is okay? That yes, their child might not be eating all the vegetables or eating 3 solid meals a day. What are some things we can point to that would be reassuring?
I think that giving them insight that we don't eat the same way every day ourselves. Sometimes we wake up hungry. Other times we wake up and you don't eat for hours. And so that is normal to see some variability from day to day. It's certainly normal when we're transitioning to all table foods off of those really easy to eat purees and liquids. It just takes longer to eat. So to try not to get too in the weeds on is it wrong, is it right, is it okay, but have confidence. I think, tracking and making sure that your child is picking up a variety of foods, even if they're not eating every single example of a category, like every fruit, every vegetable. I don't know many adults who will eat literally every fruit or every vegetable because we have preferences, but certainly having a nice variety is the goal because that's going to give us the nutrients that we need. But the sensory experience and the motor response that's required to manage those different foods is so different. So on any given day, your hunger and your satiety are a little different. Just generally how you're feeling can all impact your total intake for the day. So just let them have the meals that they take, and I guess give a little grace for those periods when maybe they don't want quite as much. Sarah, do you have any other thoughts?
I think in addition to that, the primary care physician can offer some information regarding what their growth has looked like over time. I think as we transition to past that 24-month mark, oftentimes visits become the primary care office more spread out. You're getting not that 3-6 month interval, it's closer to a year. And so sometimes I think for these families that feel a lot of stress regarding this, I think even doing a more, if it's an option for insurance and all of the other things, a check-in at a time that might be halfway between that to give, hey, let's come on in. You're really concerned. Let's keep offering a variety of food. Let's give them 3 structured meals, some snacks, but let's check in before the year, which I think can help family know, okay, I'm not out there doing this for the next year. I'm hoping it's going well. I have someone who's going to take a look at all of those things again and be able to provide additional input if needed, but also give me that check-in to say, gosh, is it going well? Are the things that we're doing working at home?
And for those, challenging toddlers, preschoolers, what are some of the things that parents can do to encourage? You've mentioned a lot of good things already, consistently offering foods, modeling, anything else with the way the food's presented or the way it's talked about that you guys would recommend?
Yeah, if you think about mealtime, every day we're doing something associated with mealtime. So you can be reading books about foods. You can be going to the grocery store together and looking at different foods and just kind of talking about them. Getting kids involved if you're doing any gardening, actually, so that they can kind of see food from the get-go. It's a great developmental experience, but it's also just boots on the ground, hands-on experience for them. Certainly as they get a little bit older, helping them involved with planning meals and preparing them. We've always said, there's a level of feeding challenge where just the sight and the scent of food can be overwhelming for kids, and they just will refuse based on just seeing it and smelling it. And so we always talk about creating a structured routine where they are exposed at mealtime when preparation is occurring, so they are smelling the smells. They're at the table with you, so they may have a small plate with a few things that are regularly accepted and maybe a small amount of something new, so that doesn't feel overwhelming. I think one of the biggest mistakes that we can make is to just assume they're going to take something and expect like just this big amount even an age-appropriate amount that could be a quarter cup at their age can look very overwhelming to them if it just looks a little suspicious to them. So, just starting off with seeing it at the table, even having like the table where you can kind of serve yourself a little bit is a great opportunity, giving choices. So would you like this or would you like this? So it gives them a little bit of autonomy, but certainly the peer modeling with their family is going to give them some great experience, getting them involved with the whole food process from every angle, and talking about foods and talking about maybe how they taste, how they smell, what they look like, what their color is. In that preschool age, we're doing so much with language development anyways. It just gives them just more information about that food that they can kind of map the sort of the motor and the sensory and all aspects at the same time.
And I think for so many of our families, we want to say, give them something preferred at every meal, whatever that comfort food, something they're enjoying. So many of our families will come in and say, gosh, breakfast and lunch seems to go okay. Gosh, dinner is so tricky. Mm-hmm. Yes, well, dinner tends to be the family and the parents selecting what's going to be available. And oftentimes there's not as much flexibility in offering a small volume of something that they may enjoy and regularly accept. Because oftentimes in this younger age group, once they get going and start taking a little bit of food at that meal, they may be more willing to explore and intake some of those other foods. And so giving them that one preferred food at every meal, but really being cognizant when we think about family dinner or that dinner time to make sure some of that's presented to them so we see a little bit more success, where oftentimes there is less preferred food and more variety sometimes provided to these families and these kids.
Yeah, I think that's a great point because, as I think about even my own kids, breakfast and lunch were often very kid-friendly foods, mm-hmm. and then we want to get more interesting and more creative and, more adult flavors with dinner. So that actually makes a lot of sense. What are your professional opinions on things like the one-bite rule or the no thank you bite, or, it goes by many names, different families do it different ways. And of course it's family dependent, but, requiring might be a strong word, but, having that kid take one bite of something they strongly are opposed to.
I think that is definitely an individual sort of decision for sure. I think it's a good idea. I want to say it's a good idea because I think there is a level of if you don't try it, how do you know? But I think Sarah and I both, over our careers, we have seen kids who it's never even crossed their lips, but they know they don't want it and they're afraid of it. So the real question is that one bite rule, is that going to trigger a fear response? And is that going to be the genesis of some further feeding challenges? And so you have to kind of
That's a tricky
walk
line
the
to
line
walk,
carefully.
Mm-hmm.
Yeah. I think generally for most kids, they can get by with that one bite rule. Even having the all done bowl on the table, we talk about therapeutically having the all done all done bowl on the table. Excuse me, I'm a speech pathologist who cannot formulate like words here today. But just that takes a little pressure off that you can try it, and if you don't like it, you can put it in the all done bowl. I tried it, great. That takes a lot of pressure, actually, I think, off of kids.
Yeah. And I think for some of our kids, that one bite rule, the no thank you bite, is going to be a fine option for the family. They've set the expectation of whatever that might be. For some kids, it's such a strong, I don't even want it on my plate. Well, gosh, if I don't even want it on my plate, I surely am not going to put it in my mouth. And so sometimes the choice can be a little bit less demanding of, okay, well, then you're going to touch it and put it in the all done bowl, or we're going to take a small smell, where we're encouraging exploration of what that food might be. But gosh, if we require a bite, oftentimes we're going to see then a spike in behavior, which then can create a battle at the mealtime, which can then really lead to it happening over and over again, or the rest of the evening looking very tricky for that child. And then we could also be instilling some of that, that's fearful for me. Or then I've had a really large negative response of gagging or vomiting or whatever else maybe, and those are larger responses. But for some kids, that's what happens when there's that strong requirement or request for an actual bite of something that is a non-preferred food item.
So it sounds like a lot of it comes down to knowing your kid, knowing what their responses are, what their, underlying anxiety levels are, or, behavioral responses to things. But it's a reasonable option, but maybe not for every kid.
Exactly.
Okay.
Absolutely.
Do you have any general recommendations on using dips and sauces and bridges to new flavors, things like that?
Yeah, I mean, if you think about, there's actually whole philosophical approaches to treating feeding disorders by looking at foods and considering the similarities from one food to another. A great example I always give to families is you're trying to go from like a liquid to a solid, and you may start off with a banana flavored drink, for example, and maybe you make that by the milk they typically drink and adding a little banana puree to it. Banana is one of those flavors that's actually really strong. It's very sweet, but some kids have a pretty strong reaction to it. The scent of it can be pretty powerful. But having that flavor, it gets the flavor started. And then you can move from that to a very thin puree. And from that, you move to a thicker puree. And from that, you can go to a banana that you have mashed down, but it might have a little lump in it, to little bite-sized pieces, to you're just taking maybe a quarter-sized bite of banana that you've sliced, all the way up to a full-size banana that you're peeling and just taking a bite from. And so when you consider foods along a continuum, it's just really helpful to consider, and we were talking earlier about success or failure might be very dependent on their moment that you offered that food at that particular time, but it might also be based on how it was presented to them. So if you consider, maybe they won't eat a baked potato today, but maybe they will eat some mashed potatoes, or maybe they will eat a soft cooked French fry, as an example. Doesn't have to be a fast food restaurant fry or anything. It can be something that's a little healthier, that's cooked at home. But just figuring out maybe what will work at that point, and then utilizing the flavors, as we said. So, salt is certainly powerful, but there's a lot of other flavors. Some kids have need for more sensory feedback. They prefer crunchy foods because they can feel them in their mouth. They prefer spicy things, actually, to things that are maybe a little more muted in terms of flavor. And so ketchup, certainly, but sriracha sometimes. Some kids are great with sriracha. They don't maybe want a basic ranch, but they wouldn't mind like a Chipotle ranch. And so sometimes we're looking for what is it that your flavor profile might be interested in, and then we'll kind of work with that and try to move it to other things, because you can use the same dip for a variety of different foods, and then you got like a nice bridge from a banana to something that's maybe an apple, or to even a different food group. Could be a vegetable, for example.
I think for a lot of kids, that consistency of, I know I like ketchup, or I know I like ranch, and then it being an option to try all these different things, and we're then experiencing maybe a slightly different texture or a slightly different flavor profile because it's being dipped in that vehicle of whatever the dip may be. That can be a very successful way for a lot of families. And oftentimes parents will think, well, that doesn't sound like a flavor profile that sounds good to me. And I always say, doesn't matter if it sounds good to you, if it's successful for them, gosh, let's give them that dip. Let's give them that way to explore some other things by using that consistent thing that they know, that flavor of barbecue and ranch or ketchup I like. It's a way to experience some of those newer things, and can really be a successful way of increasing some of those other foods that the family is hoping they'll take.
So lots of great ideas of how to introduce foods, how to encourage our kids and our patients to try new things. When does it come to the point where you think we need to get a higher level expert, a speech and language pathologist involved? When do we get to that referral point?
Yeah, I think there are some really good, strong behaviors that you're going to hear. So in an infant, you're going to hear a family who is saying, every mealtime they go to sleep, I try to start feeding and they just kind of conk out quickly. Or they seem hungry, and I offer the bottle or I start breastfeeding, and within 2 or 3 minutes, they're just miserable. They're crying, they're arching, and they just seem incredibly uncomfortable. Or they're gagging, they are coughing and choking. So those are usually like pretty clear signs. But I think that it's not a one-time thing that happened. It's like it's becoming a pattern, because every feeding that we do, we are learning from. You're learning to reinforce positive behavior, or you are learning maladaptive behavior, actually, refusals. Like a child learns very quickly if something scares me or overwhelms me or causes me pain, discomfort, or gagging. I can just close my mouth and turn my head, or I can sit at the table and cry. And eventually someone will give in and say, okay, never mind, you don't have to take that. Babies actually as young as 2 months will start demonstrating that behavior, unfortunately. So if you see behaviors like that in infancy, I think that's important. I think we talked a lot about it's at transition times. It's not uncommon to have periods where they might gag because it's a different texture, even a different flavor. But if it persists, if they flat out refuse and they are stuck, they're breastfeeding or bottle feeding only, and they do not transition, and family has been trying it for weeks and weeks and weeks, and you start seeing maybe associated behaviors like crying or pushing it away, consistent gagging, I think those are good indicators. Anytime you get a child who becomes very dependent on only maybe 1 or 2 different sort of types of food, so like liquid and puree only, especially thin puree, that's usually a good indicator there might be something going on from a sensory or motor perspective. You start losing foods and they're not coming back. I think those are some really big ones. Sarah, any other thoughts?
Yeah, I mean, I think sometimes as we move into that toddlerhood and early preschool age, we think about like variety and number. We generally say, gosh, if they're eating less than 30 food varieties, it might be a time for someone to look at that motor and sensory profile and see, gosh, is that impactful? And are they limiting for a specific reason? So we think about looking at what are they taking? What does that variety look like? If they're missing whole items of food groups, so if they're not consuming any protein sources or any vegetables or any fruit, that might be something to look at and see, gosh, is that problematic? What is that looking like for their overall growth and nutrition? And then thinking about also, what is it looking like from a family dynamic perspective and a mealtime structure? Are they eating all day long and never really, they just snacking, then drinking, then snacking, then drinking? And is that impacting? And if they structure that, is that tricky for them? Is the child unwilling to come to the table? Is every meal ending in tears for the parent or the child? Those are all part of a feeding experience. And so looking at how can we support the family and the child to be successful, because like we said before, feeding has to happen multiple times a day, and it has to happen for a lifelong experience. And so how do we make that look positive, both from a medical perspective, but also from a family perspective?
So you mentioned, Brenda, all the different transitions and types of foods, maybe getting a little more to opinion side, but, over the last 10 years, the rise of the pouches, the fruit pouches, the basically applesauce. But, do you feel like over your careers, has that changed anything? Has that,
yes. Yeah. For many years, the therapy world talked about the sippy cup being the bane of our existence. So you think about babies have a suck-swallow pattern. And if you don't ever transition to open cup drinking, you don't develop jaw stability, you don't develop the ability to form the oral cavity in a way that you can collect a bolus of liquid and swallow it without utilizing a suck-swallow pattern. The pouch has become the new sippy cup. And, as a parent, they didn't have those when my kids were little, and the flavors are amazing. Haven't tried one, but in the swallow studies and clinical evals we do, families will bring those in, and I am in awe of the variety that they have. I do feel like the pouches are perfectly fine when used as a convenience, but we have a lot of families who will come in and say they've never tried spoon feeding and they're 2.5. And to us, you lose out on oral motor experience that is at a critical phase of development. And so it's just really important to just always remember everything in moderation, I think, probably be used for almost any discussion.
Absolutely.
So I'm just going to throw that one in there right now.
I mean, I think so many of those families, it is convenient and the kid's willing to take them, but I think we're missing both a sensory experience and or a motor experience from an oral motor perspective, but also from a development of wanting them to encourage self-feeding with a spoon. If it's only ever from a pouch, that is not going to provide those experiences. I often find, too, for some of our kids where they've gotten stuck a little bit there. Yeah. They can look and they're like, I like the blue one, and it's the blue one from Kroger only, and it's so visual for them versus if it comes in a container or it's poured out of the yogurt container in the refrigerator, it looks so drastically different than the kids who sometimes get stuck in that brand specific, flavor specific, and they've gotten, it's so visual for them and they've gotten stuck there. And so I think there is convenience. I think there's the benefit of a larger variety of flavor profiles for some of those kids. I think sometimes when they're mixed, though, kids that don't experience this is what broccoli tastes like. Yes. Because I will only eat broccoli when broccoli is also with pear and zucchini. And so we miss some of that development also. And so they are great for moderation and for some convenience, but definitely need to be used in addition to a larger variety of textures and skill development options.
Mm-hmm. Yeah, I don't think I've made that part of my proactive anticipatory guidance to limit those, but certainly I see it on the other end when it's become the only delivery vehicle of vegetables or
and
foods.
We celebrate it when that is the only way you get it. So yeah, there is a school of thought. You don't take away what is serving them. You try to build new skills so that they can transition from them when they can. So they are definitely valuable, and I don't mean to demonize them in any way, but I do think that the variety is certainly much more expansive than it was 20 years ago.
And even in the last few years, it has drastically increased the number of single ingredient meat options, and it's shocking to me. And so for some of our kids, using it as an option to let's keep eating them, but let's see if we can put it in a bowl. Let's see if we can then eat it off a spoon. Let's see if then we can try whatever that flavor profile that you love. Let's see, can we have it finely chopped and see if you'll then accept it. And so we want it to stay part of their nutritional intake because if that's what they're limiting to, but we don't want them to stay stuck there. We want to be able to keep moving them in a way that developmentally is going to support them long term.
One other thing that just gets me thinking about how we can support our families, we are often all very busy and it's not easy to take the time to make your own foods for your children. But there are options that you can buy pouches and you can make your own. What a great idea where you can say, you love pouches, you love these combined textures. Let's work together and puree one together so that you see what's going into that. And then let's try the pieces that went into it. It's probably already sort of soft cooked. And so it's very often possible that you probably could kind of pair that, I would say, with the pureed version and just increase their just expectation and understanding of what went into that.
That's great. I love that. Thank you so much. Are there any groups or populations of kids who are at higher risk for excessively picky eating? Almost bordering on pathologic picky eating.
Yeah, well, I think what's helpful to hear is typically developing children, between 20 to 50% of typically developing children will have feeding challenge at some point in childhood. So just knowing that is probably shocking, but also important to hear. Anybody who has medical complexity at all, they have a much higher risk of having some feeding challenges. So the medically complex kids, the patients who are born very premature, patients who require a lot of hospitalization, intubation, surgical procedures that could have impact to their sensory experience, being intubated for a prolonged period of time. There's just a lot of life-saving care that occurs that also has a side effect of creating just an abnormal sensory and motor experience for these kids. They have prolonged periods of non-oral feeding, sometimes non-enteral feeding. So their hunger and satiation is radically different. And so we try to, in advance, be educating families how to support their child, exposing them to colostrum for mouth care, exposing them to breast milk for scent, for taste, formula if families are choosing formula feeding, so that we're sort of programming positive oral experiences while they're going through a lot of negative experiences, and then just trying to kind of contribute to just continued positive development over time. But yeah, I'd say the medically complex kids for sure are the high-risk ones. Anyone who's showing upper respiratory infections, a lot of coughing, choking, congestion, if you've got cardiac condition, if you've got GI conditions, feeding, as we've said, it happens multiple times a day. And whether through your internal experience with eating, it may cause you discomfort, gastric discomfort, it may cause reflux, it may cause you to have emesis. Those things happening on a routine basis, kids map that. They learn that, that's that flavor that I just ate. I am not eating that flavor again. Some kids, if they throw up, they had a hot dog that day, they will never touch a hot dog forever. I mean, it might be years. And I think the other interesting thing is that early feeding behavior, if not addressed, will get worse if it's an underlying pathological condition without a supportive intervention. And even with intervention, sometimes it takes a very long time. And some kids, it can be really challenging. It's a real battle for families, I would say.
I think additionally, when we look as they're a little bit older, any of the kids who are diagnosed with the autism spectrum disorder, they have a lot of routine and rules and about their life in general. And so that becomes oftentimes in feeding also. And so they might be very brand specific, they might be very texture specific. And so some of that variety may be very hard for them. Kids who present as having gross motor difficulties and have been late to walk, delayed to walk, oftentimes they struggle with oral motor skill development. And so that ability to transition to table foods can be hard for them because they're missing some of those developmental skill sets. But as families, we're looking at the timeline and we're offering the next thing, and they're experiencing not great experiences. And so they learn very quickly, no, thank you, that didn't go well. So I'm just going to stay at whatever that texture that I've got the skill set to work well for. And so if it's a child with delayed or with global motor skills, so this kids with cerebral palsy, they're going to be at risk because their skill set from a motor perspective are impacting. But I think oftentimes when we think about some of our other toddlers, it's those kids who are on the autism spectrum disorder that really have some difficulty with increased variety. Sometimes as kids get a little bit older, so outside that toddler, they tend to be kids who have anxious behaviors in a variety of areas. And so they're really struggling with transitions across the board. They're really limiting on how their sensory experiences throughout the day. They oftentimes have a lot of anxiety and limit about the foods that they're going to take. And we don't understand as the parents and the providers why, but we want to be able to support getting increased variety and increased intake for them.
And besides the things you've mentioned already for the general picky eater, is there anything in particular that you would recommend for our patients on the autism spectrum and their parents of how to help them widen their variety?
I think oftentimes trying to find things that are very similar in texture or in color, and then slowly changing them. And so sometimes I think about, gosh, they love crunchy foods. And so we're going to start with a crunchy pretzel to a crunchy Teddy Graham to a crunchy, really crispy chicken nugget, and then a fish stick, all brown, all crispy, but hoping to get some more variety. I think that those days it's tricky for families to get it to where they're willing and accepting, but oftentimes if we find one kind of characteristic of a food that they really like, we don't want to take away what they don't like. We want that to still be available, but slowly chaining those things together to see if we can get a little bit more variety and staying in kind of that same level of comfort for them.
Yeah, and I think that that transition process that you just described, that chaining, the characteristic, it's important, I think, to expose, and sometimes it is important to just allow them to be present with that food to the level that they're capable in that moment. So it might be, I see it on my plate there. I'm not going to touch it, but I see it there. Okay, I can handle that. Or it might be, okay, I can touch it, I can move around, I can paint with it, I can take it in a dip and make a little design, to I can smell it and I'm okay with it, I can rub it around my mouth a little bit, I can touch it to my tongue and then I'm all done. So we have ways where we can kind of gradually, it's sort of systematic desensitization. It's the same concept where you're taking something and you're just gradually working a hierarchy to get to a point that they can be successful. And parents need this. We just had a family recently with multiples that have autism, and they are struggling. It's at 5 foods. They've got 5 foods in the diet, and it is terrifying to know what to do next. And sometimes it's not easy to find a provider in your area, and we certainly are resource-rich in our environment, but we have a lot of families who are coming from rural areas from hours and hours away, and it's a struggle. And to understand that lived experience for those families, you've got to give them hope. And so sometimes it's okay, we're going to get there. It might take a while, but this is the process that we're going to follow, and how you respond to when they start to get a little anxious about it, how you back off, and then try to approach it again, because there's a way to approach it where they will start interacting with it more, and eventually it will lead to acceptance.
So, Brenda, I think that point you make about giving those families hope, saying this is going to get better, and more importantly, we're going to be right there with you is just such an important piece of this. Sometimes, though, we do need a little extra help as a primary care provider. When do we refer to the different specialists out there? You know, it might be a speech therapist or speech pathologist. It might be occupational therapist. If the community has a multidisciplinary team, how do we choose which specialty to refer to?
I think you learn who your providers are and what you're going to get from them. A feeding therapist can be a very multimodal kind of therapist in a lot of ways. Certainly, I've worked with a lot of speech pathologists and occupational therapists over the years who've had extensive experience working with feeding. Speech pathology has a skill set that really relates to just oral motor functioning, swallow physiology for sure. We also are very adept at working with feeding, but occupational therapy also has that skill set from a motor background and the sensory perspective as well. I think dietitians are critically important. So really determining if your underlying question is a feeding problem and swallow dysfunction, you'd probably refer to speech pathology. If you feel like I'm not so concerned about maybe swallow physiology, but wow, we've got some sensory issues here and some real limited intake, you could probably look at speech pathology or occupational therapy. If you are concerned about just growth profiles, it might be helpful to start with a therapist, speech or OT, and get that nutrition input. But I would say ultimately, no matter who you get, we will do a comprehensive assessment and give the family and you as the provider all the details of what we think is occurring and maybe what we would recommend to sort of support. We'll also recommend maybe some additional referrals based on our clinical experience. Sometimes we'll see kids who it feels like there may be a swallow dysfunction, but it sounds like airway is driving. There's a lot of stridor going on, for example. So we might say it might be helpful to get an ENT to take a look at this child with us. So maybe we would want to go down that path as well. So I just say, figure out maybe what your question is first and determine maybe your first provider with the expectation of just a great conversation afterwards to figure out maybe what are additional next steps we would need. Sarah?
Mm-hmm. I think some of it's thinking about what locally you have, what providers might be local for you, and figuring out, gosh, if we have only a certain provider skill set available in our area, that's going to be where feeding can be addressed. thinking about also when we think about a multidisciplinary feeding team option, we generally think, gosh, they need to have the need for multiple providers. They need to have that medical portion to be looked at, either from a physician or a nurse practitioner. We want to look at, gosh, what's a registered dietitian going to be able to provide from a nutritional perspective? And then therapeutically, what can we provide from a therapeutic intervention and therapeutic assessment from either occupational, speech, both of those, and kind of what instances would be most appropriate for that larger comprehensive assessment, both looking from a medical, nutritional, and therapeutic at the same time versus a single provider that might be available in the community who's going to look at, gosh, oral motor wise, sensory profile wise, swallow function, what can we do to support them? Because oftentimes with what we see with these kids is they're going to need ongoing therapeutic care. And so we want to make sure that whatever assessment's going to be provided, that therapy is going to be part of that. And so getting into either speech or OT can be in a combination with a medical assessment and a nutritional perspective. We're the ones that are going to be generally feet on the ground, seeing the family on a consistent basis to help make changes long term.
Sarah, Brenda, thank you so much. I've taken so much from this conversation. For our listeners, just as a reminder, today's episode is available for CME credit. You can find the link to that in the show notes. You can find more information about all these things at the speech language pathology page on CincinnatiChildrens.org. And I hope everyone has a great rest of their day.
Thank you.
Thank you.